major adverse cardiac events are reduced when we are using semaglutide. Now we will hear from Dr. Santosh, who is an endocrinologist, and he runs a Magna Center for Obesity, Diabetes and Endocrinology at Hyderabad. Let us hear from him about the oral semaglutide use as a soulful solution in this multiple, giving its multiple benefits. Over to you, sir.
Thank you, sir. And thank you to the organizers for inviting me to Mangalore, a city which is very close to me. Thank you. So we'll start with this particular topic, the soulful solution advancing the cardio-kidney metabolic health. Now, why are we using this word cardio-kidney metabolic health? So it is now a recognized syndrome. We call it as the CKM syndrome. We have to realize that type 2 diabetes, it rarely occurs in isolation. So the American Heart Association, they define something called as cardio-kidney metabolic syndrome, which is a systemic disorder. It is characterized by pathophysiological interactions between metabolic risk factors like type 2 diabetes, hypertension, dyslipidemia, obesity, chronic kidney disease, and the cardiovascular system, leading to high rates of adverse cardiovascular outcomes. Sorry for that. So the stages of the cardio-kidney metabolic syndrome are, you can see that it is made by the cardiologists, but yeah, it's a very useful syndrome diagnosis nevertheless. Stage 0 is when there are no risk factors whatsoever. Stage 1 is when there is excess or dysfunctional adipose tissue. Stage 2, patient has already started developing diabetes, hypertension, dyslipidemia, metabolic syndrome, and also early stages of chronic kidney disease. Stage 3 is when patient is already undergoing subclinical cardiovascular disease such as subclinical ASCVD, subclinical heart failure, or high to moderate risk CKD. And stage 4 is when patient has already developed a clinical CVD. For example, patient has already had a CHD, heart failure, atrial fibrillation, PAD, or stroke. So basically what we want to try to understand here is, in the CKM syndrome puzzle, there are 3 components. One is called as the initiator component, that is the metabolic dysfunction, that is hypertension, diabetes, dyslipidemia. There is an amplifier component, that is the presence of chronic kidney disease, and finally the outcome component, that is known as the cardiovascular disease. Now for solving this cardiovascular CKM puzzle, we need one last piece, that is solution for CKM syndrome. And it is no surprise when we talk about a potential solution for CKM syndrome that will help in reducing all these components. Blood glucose should come down, the BP should be improved, the cholesterol should be improved, the weight should come down, it should be protective to kidneys, and also it should be protective to the heart. And you know where we are getting to, GLP-1 receptor agonist. So GLP-1 receptor agonist, as we know, has multiple mechanisms of action. It doesn't only act on the pancreas as it was previously thought. In this particular slide, you can see where all GLP-1 acts. GLP-1 acts on the pancreas. What does it do there? Glucose-dependent insulin secretion. It also causes glucagon suppression, has some proliferative effects on the beta cells as well. But it also acts in the liver. In the liver, it suppresses the hepatic glucose output, reduces the fatty acid synthesis, and reduces the fat deposition in the liver, also brings down the inflammation in the liver. It acts in the brain also. In the brain, what does it do? Suppresses the satiety and increases the satiety and suppresses the appetite, and also reduces the risk of stroke. What about the cardiovascular system? GLP-1 has direct effects on the cardiovascular system also. It's improving the blood pressure. It's improving the dyslipidemia. It's improving the atherosclerosis parameters like endothelial function is improving, plaque stability is improving, the vascular inflammation is improving, blood pressure is also improving with this particular therapy. In the kidney also, GLP-1 has effects. It increases the diuresis, increases the sodium excretion, and reduces blood pressure. So it's one molecule which is acting on multiple components of the same thing that we are talking, the CKM syndrome. So much so that all the guidelines are now talking about GLP-1 receptor agonist. The European Association of Study in Liver Diseases says that if a person has fatty liver and diabetes, use GLP-1 because it will help in weight loss. The KDIGO guidelines are telling if person is having diabetes and kidney disease, use GLP-1 because it will improve the kidney problems. The European Society of Cardiology is saying if a patient is having diabetes and cardiovascular illness, give GLP-1 independent of the HbA1c control because of its cardioprotective effects. And the American Diabetes Association ESGD also says that in a person who's having multiple cardiovascular risk factors or high risk for CKD, start GLP-1 because of its nephroprotective and cardioprotective effects. So today's molecule in contention is oral semaglutide. Oral semaglutide is now there for the last 4 years, 5 years. We're using it regularly. What is the evidence with oral semaglutide on the CKM initiator, that is the metabolic dysfunction? Significant HbA1c and weight reduction is seen with oral semaglutide. 6,645 patients has been exposed to semaglutide in the phase 3 trials, and they found out that 7 out of 10 patients in the phase 3 trials achieved an HbA1c of less than 7%, and the reduction of HbA1c is anywhere between 1.1 to 1.5%. Reduction of weight with oral semaglutide is 3.5 to 5 kgs. And if the HbA1c is high, the HbA1c reduction is even better with oral semaglutide. Therefore, we know that it controls the blood glucose now, and it's also helping in weight. Even if you take a composite outcome of HbA1c reduction greater than 1%, body weight loss greater than 5%, oral semaglutide was doing much better than all the comparators which they use in the phase 3 trial. And among the comparators, empagliflozin was there, which we know controls BP and sugar and weight. And there was also liraglutide. Liraglutide also reduces weight and controls HbA1c, but semaglutide was outperforming both these agents as well. This is a major concern asked by doctors and patients alike. When you are reducing weight, what will happen to the muscle mass? So there was this particular study where 32 patients were followed up on oral semaglutide. Not only there was reduction in body weight and waist circumference and BMI, what the authors saw over there is the fat mass index was coming down, the visceral adipose tissue was coming down, whereas the free fat mass index and the skeletal muscle index, that means the ratio was actually improving. That means the lean body mass was actually getting preserved, whereas the fat mass was coming down with oral semaglutide. What about the effect on blood pressure? So obviously if a person is losing weight and it has some pleiotropic effects on the vascular system, oral semaglutide itself helps in reducing the BP by around 5 millimeter Hg, and we know that if you reduce the BP by 10 millimeters Hg, we are going to prevent microvascular complications, macrovascular complications, and even death. Oral semaglutide, due to its pleiotropic effects, also has an effect on the lipid profile. LDL cholesterol, the total cholesterol, the triglycerides, all of them are better controlled as compared to placebo in the phase 3 trials. Of course, it is not a lipid reducing drug, but it's a good result to see nevertheless. The CRP is a biomarker of cardiovascular risk, vascular inflammation. Semaglutide was helping to reduce the vascular inflammation 4 times more than empagliflozin. So it augurs well with the idea that GLP-1 receptor agonists, they prevent atherosclerotic heart disease. SGLT2 inhibitors, they act mainly in the pump. They prevent heart failure and therefore they affect the cardiovascular outcome that way. GLP-1 affects atherosclerosis more. What is the evidence of oral semaglutide on the chronic kidney disease? So as with every anti-diabetic agent, first they will try to find out whether the agent can be given safely in patients with kidney disease and whether it causes any other side effects. So Pioneer 5 study was that way only. It was a phase 3 trial which was done in patients with EGFR of 30 to 59 ml per minute. And what they found out that even in this group of patients, semaglutide was able to bring down the HbA1c to around 1%. And the weight was also coming down by 3.4 kilograms, showing that it is safe in patients with CKD and there is no dose adjustment required even in low EGFR values was what was found here. But it's also seen that we have good effects on the hemodynamic functions as far as the kidney. So is it helping to slow down the progression of chronic kidney disease? This was a study that was done from Japan. It was a retrospective study. And they found out that those people who are using oral semaglutide, their baseline EGFR actually increased a little bit. It increased after using semaglutide. It was not significant, but it definitely increased a little bit. Whereas the urine albumin creatinine ratio came down by 50%. Therefore, that shows that good BP control, good sugar control, and weight loss causing by oral semaglutide is actually benefiting the kidneys also in the long run. Now we come to the main part of the trial talk today, that is the evidence of oral semaglutide on the CKM or CVD events. So Pioneer 6 was a regulatory trial. So they took very high risk patients and they compared it with placebo, and they showed whether semaglutide is cardiovascular safe or not safe. And yes, in Pioneer 6 they saw that compared to placebo, oral semaglutide was not causing any further harm as far as the cardiovascular system is concerned, and it got a regulatory approval. The main cardiovascular outcome trial is called as the Soul trial. So Soul trial data is now released, and it was a trial which included 9,650 participants given oral semaglutide or placebo for 5 years and 2 months, and they saw what was the outcome. 800 of these patients were actually from India. Inclusion criteria, they took people with type 2 diabetes above 50 years of age, HbA1c between 6.5 to 10%. These people should already have had one of the following. The patients were already having either a cardiovascular illness, cerebrovascular disease, symptomatic CKD, and symptomatic peripheral arterial disease, and they wanted to see what was the effect of oral semaglutide in this group of patients. They excluded people who had just had an event. So somebody who has just had a myocardial infarction or just had a stroke, they were not included in the study. Or somebody who was being planned for revascularization, they were not included in the study. And if any other GLP-1 was also used 1 month prior to this, they did not include in the study. A male to female ratio was 71 to 28.9. The mean age was 66 years. And Asian population was well represented in this study. So most of the times it was done in Caucasians. In this study, we had a good amount of Asian population as well. HbA1c was 8%, BMI of 31, and type 2 diabetes duration was 15.4 years. Coronary heart disease was there in 70% of the patients, cerebrovascular disease in 21% of the patients, CHF in 23%, and peripheral arterial disease was seen in 15.7%, and 42.4% of the people already had some amount of CKD when they entered into the trial. Now, it's very important to see this, the concomitant medication. So nowadays, in the trials, patients are already using RAS inhibitors. Many of them are already using beta blockers. Many of them are using statins, antiplatelets, diuretics, and sorry. So by the time the study was done, many people were already using SGLT2 inhibitors as well. So what was seen over here is, so remember here in this trial, in one group, oral semaglutide plus standard of care was given. In the other group, placebo plus standard of care was given. That means the standard of care is giving cardiovascular protection to everybody. The only difference is semaglutide versus placebo. And oral semaglutide was actually helping in the primary outcome. It was decreasing the risk of the 3-point MACE by 14%. In many trials, you'll see that the 3-point MACE is mainly because of heart failure or mainly because of cardiovascular death. In this trial, all three components of the 3-point MACE were contributing equally. Non-fatal myocardial infarction reduction was most important over here. Benefit with oral semaglutide was independent of the gender, independent of the baseline HbA1c, independent of the age, it was independent of the BMI, independent of the EGFR value. And what was very interesting to note is that in Asian patients, it was showing a much better effect as compared to the Caucasian patients. And those patients who had a higher HbA1c, obviously it was showing a better effect as compared to those who were having a lower HbA1c. They wanted to see what happens to the kidney outcomes also, and they found out that the kidney outcomes were also getting improved with oral semaglutide. Although it was not a statistically significant difference, numerical difference was definitely there. Those patients on oral semaglutide were doing better kidney-wise also. Now, this is a very important slide for us endocrinologists and people who practice diabetes, is what is the effect over and above SGLT2 inhibitors. Oral semaglutide appears to reduce the risk of MACE regardless the use of baseline SGLT2 use. So oral semaglutide brings down the the 3-point MACE by 11% when the patients were already using SGLT2 inhibitors and 16% when they were not using SGLT2 inhibitors. Therefore, I stress in multiple talks that SGLT2 inhibitors and GLP-1 receptor agonists are friends. They are friends, they are not enemies. SGLT2 inhibitors, already we are having generic versions. So if you are giving GLP-1 receptor agonists, that doesn't mean you don't give SGLT2 inhibitors. Both act in different mechanisms to to control the blood sugar, to control the weight, and also to protect the heart and kidney. Side effects were reported in fewer participants in the semaglutide group, and adverse events leading to permanent treatment discontinuation was more in the semaglutide group. Why it was more in the semaglutide group is many people did not like the GI side effects. So that is also seen in our common practice. When we start oral semaglutide, around 7 to 8% people, they drop out because they don't like the GI side effects. But the remaining 90% patients definitely benefit. So where does oral semaglutide compare with all the other oral antidiabetics that are present? Among the oral antidiabetics that are present, the highest glucose lowering efficacy is with oral semaglutide. Effect on body weight is highest with all the oral antidiabetics that are present. Cardiovascular risk reduction is equal with SGLT2 and oral semaglutide. Pleiotropic benefits are there, and hypoglycemic risk is low with oral semaglutide. So is it with SGLT2 and DPP4 inhibitors. So with that, I think I'll rest the case here. Thank you.
Thank you, sir, for drawing attention to multi-system benefits of oral semaglutide. Dais is now open for discussion.
Thank you, sir. You have beautifully highlighted the various benefits of semaglutide, especially in connection with the 3-point maze effects. Now, my question to you is, see, it's almost effective, like when we are discussing about obesity, we have found the role of parental semaglutide. Why not we start with the oral only? Because even with the BMI of around 31 in your study, that
Correct.
it has been very effective. So where exactly this role for parenteral semaglutide stand?
So if you have to compare oral and subcutaneous semaglutide, as far as weight loss is concerned, subcutaneous semaglutide is definitely far better. So if the primary aim of your treatment is to help the patient in reducing weight, subcutaneous semaglutide will definitely work better. Whereas a person who is in chronic therapy does not want to take injectable therapy, but we still want to give the benefits of GLP-1 receptor analogs, I think oral semaglutide we are still giving to multiple patients for that fact.
GI side effects are much better with the parenteral, sir, or is there any?
They are almost same.
Same.
Oral and subcutaneous, they are almost same. So we also have submitted our data actually where we have studied what is the effect of oral semaglutide in people with type 2 diabetes and fatty liver disease. And there was a significant reduction in the fatty liver disease content, and that has got accepted in the American Association of Liver Disease. I am going to go present that data with oral semaglutide in type 2 diabetes. Therefore, it has a lot of pleiotropic benefits. The only problem I see over here practically is whether patients are able to afford it and continue it for a long period of time. Even in the best, in Western countries also, many people, they stop after 4 or 5 months because they don't like to take the tablet early in the morning and other things. But rest assured, if a person is actually taking oral semaglutide for a long period of time, he or she is going to benefit quite a bit because of its pleiotropic benefits besides weight loss and blood sugar control.